thankful to Mina Sino Forum to give me opportunity to bring this case over here. The main aim to bring this case discussion over here in this great forum to take the advantage of presence of the great names here to get the expert opinion in the management of this case so that we all can get benefited from this discussion. Our case, the patient is a 32 years old female, recently presented in our department with off and on history of headache, non-specific, and she also noticed for last 2 months the mild right eye proptosis. There is no known history of the comorbidities and no relevant past medical history of hemorrhage or stroke. On the examination, her visual acuity was unremarkable bilaterally, and the neurological and the rest of the systemic examination was unremarkable as well. She underwent the MRI for the further investigation for her headache, and the imaging findings on the MRI were of the bunch of vessels seen in the occipital region with a closer vicinity of a dilated ectatic vein draining it into the left transverse sinus with coexistent the venous congestion that is visible. We can see it in the right Sylvan fissure as well, and in the lowest mode image you can see the prominent superior ophthalmic vein as well. For the further investigation of the case, we can see the scroll down images of the MRA as well, which can easily show the bunch of vessels being built up in the left occipital region with the dilated ectatic vein at its closer vicinity and draining into the ipsilateral transverse sinus, and the venous congestion is also visible in its closer vicinity, and the prominent superior ophthalmic vein can also be seen. These are the 3D images reconstructions for the images showing the bunch of vessels in the left occipital regions with the arterial feeders from the middle cerebral artery and the posterior cerebral artery as well, and the few feeders from the left occipital artery can be seen as well. The patient underwent the digital subtraction cerebral angiography. To first go with the right IC selective angiogram, we can see the adequate opacification of the vessels with the good cross flow. And on the lateral images, we can see the fetal origin PCA. On the right external carotid artery selective angiogram, the important thing we saw, the early arterial opacification of an ectatic vein in the left occipital region draining into the transverse sinus and being fed by the right middle meningeal artery feeders, as seen in these images. Just to move on further, the left external carotid artery selective angiogram, we can see the feeders from the left occipital artery and the middle meningeal artery being fed by the same to the same ectatic vein which were early opacified on the right side MMA feeders, and to the having the venous drainage into the transverse sinus. The cortical venous reflux is also visible as the important prominent vein draining into the superior sagittal sinus. Similarly, on the lateral view, we can see the occipital artery feeders proceeding towards that ectatic vein, and early, which is showing the early opacification in the arterial phase, followed by the adjacent blush of vessels in the closer vicinity of the transverse sinus. On the left IC selective angiogram, as to proceed further, we can see the bunch of vessels being opacified closer towards the left occipital region in the draining into the same ectatic vein which we were talking about earlier into the transverse sinus, and the bunch of vessels which is the avium nidal, likely nidus is being filled by the feeders from the middle cerebral artery. We can see the cortical venous reflux as well, and the dilated ectatic vein draining into the superior sagittal sinus. The similar findings were visible on the lateral angiogram. We can see the feeders feeding from the middle cerebral artery posteriorly, contributing to the AVM nidus in the closer vicinity of the transverse sinus being drained by the ectatic venous channel we talked about earlier. As we can see in the late venous phase, in this phase, the left sigmoid sinus was also a bit attenuated as compared to the right side, though the left being the main venous drainage of the brain in this case. To proceed further with the left vertebral arterial angiogram, we can see the feeders from the left posterior cerebral artery feeding to the AVM nidal, which is seen in the previous location as we have seen it earlier, along with the venous drainage, the same as described earlier. This is on the lateral view. We can also see the arterial feeders from the posterior cerebral artery contributing to the AVM nidus, draining into the same ectatic vein as that of the drained by the feeders from the bilateral middle meningeal artery and the left occipital artery into the transverse sinus. Depending upon these findings, the diagnosis of the dural AV fistula left occipital region drained by an ectatic venous channel into ipsilateral transverse sinus and associated cortical venous reflux was made with a coexistent bunch of small vessels supplied by the left middle cerebral artery and the posterior cerebral artery feeders having the same venous drainage concerning of coexistent small AVM with differentials of the dual pial feeders. Our multidisciplinary meeting team was taken on board, and considering the unique clinical implications and the surgical endovascular treatment of both coexistent dural level fistula and the AVM in close proximity, considering that it can be technically challenging, the plan of the one-go embolization followed by the surgery was made, and the patients, though the patients with coexistent vascular anomalies need long-term surveillance and the follow-up and the monitor recurrence, complications, and other vascular lesions. Now I will request my experts, seniors, over here to bring their expert opinion and their previous experiences regarding such cases so that we can all get benefited with this discussion over here.
Thanks, Dr. Sadiqi.
So I'm not quite sure exactly what the diagnosis, if the diagnosis is correct. So if I interpret this, I think this is probably a PL arteriovenous malformation, probably resulted in thrombosis of the draining vein, secondary recruitment of dural arterial supply of a PL AVM that can happen rather than just a simple dural arteriovenous fistula. I think that's the more likely diagnosis and probably consistent with the patient developing symptoms, probably related to venous thrombosis. In terms of treatment options, I think this can probably be treated entirely endovascularly as well. I'll probably start with PL embolization followed by extracranial if needed, maybe even transvenous. Surgery is a perfectly reasonable option. I think radiosurgery is a perfect option. So you can skin the cat many ways. But I think this is probably a PLAVM with secondary recruitment of dural vascular supply rather than two separate pathologies in the same place.
Yeah, I do echo exactly what Adnan is saying. So we have seen a few patients that were partially embolized 10 years ago, and they came for follow-up. And there's a big portion of those AVMs recruit from the dura. And then if you do an angiogram, it looks exactly like this. So I think it's a single diagnosis, which is arteriovenous malformation, but has, for some reason, recruited blood supply from the dura. And, you know, as Adnan mentioned, it could be a partial thrombosis that resulted in that. But if someone has been embolized in the past partially, that also can predispose for that. And the treatment would be exactly how you treat an arteriovenous malformation, not how you treat a dural fistula. Because if you approach it a dural fistula, you're going to occlude the vein without taking the nidus, and you're going to result with bleed. So you're going to treat it exactly like an AVM, and you start with the intracranial component for that. So you're going to go for the PCAs, feeders, and then at the end, if you need to come from the external, you can come back, but you're going to need to start from the intracranial feeders.
Before Adnan gave the comment, I wanted to give you a comment, and I have the different view, and it's just to please you, because otherwise you could feel that you are not good enough, that you didn't understand this anatomy. In my practice, I've seen several cases that turned out to be dural fistulas with recruiting bile vessels. And this is what my approach would be, that I thought that this was primarily a dural lesion and then recruited some bile vessels, but it's difficult to say what was the first, the chicken or the egg. So I think this was very good that you took up this case, because there is a discussion, and you see that not all the experts, so-called experts, are on the same opinion. What I think also, someone has mentioned this was an unruptured case. If you have access to radiation therapy, you could think about, because it is a quite small lesion, if there is a nidus or there is a fistula, radiation may work. It is not high risk, and then you can, after 2 years, probably see maybe it can cure whatever it was from the beginning, either AVM or a dural fistula. I would go for radiation if it is available in your institution.
So we were initially thinking of the same regarding the SRS or in the radiosurgery for the patient, but actually considering the coexistence of the dural fistula, because which has the highest risk of rupture and presenting as a hemorrhage as compared to the AVM, because after the radiosurgery, the latent period in which we can assess the treatment, whether it is effective or not, is approximately starting from the 18 months to 2 years. And during that time, the patient has the high risk of being presenting with the hemorrhage with the fistula, as that's why we
the fistula has higher risk if it has bile drainage. But this has no bile drainage. It goes directly to the shunt, to the sinus. Sorry. So I don't see it is a very high risk for rupture. And when did you discover this? It was a year ago.
No, sir. It's just a month back.
A month back.
A month back, this patient came to us.
Did he?
I would tend to concur with my colleagues that this is an occipital AVM, and it has actually recruited blood supply from multiple sources. The main problem with these patients is what to do about the vision once you treat them, because I have an experience with a couple of these cases, and fortunately Umair might be remembering one of them. We embolized it with onyx and then we excised, and the vascularity was dramatically reduced. So the excision is not a problem in this case, multimodal treatment, but the problem is that these patients, they might suffer from a visual deficit and they carry it for probably with the rest of their lives.
I think this is also a case for the radiation therapy. It's the same.
So thank you very much for the kind comments and the expert opinion. Thank you very much, sir.
Thank you.
Thank you.
Thank you, Dr. Khshboo. That was a very good presentation. Now I would request Dr. Wali. He's a neurologist from Quetta, and he's working currently with Dr. Umair at Lord General Hospital. He would shortly present his case. Please, Dr. Wali.